Good morning. Thank you so much for your patience while we worked out our technical difficulties. We'll extend the length of the forum a bit to allow all of our speakers their agreed upon times. I'm Amy Rowley McGee, the president of the Health Policy Institute of Ohio. Thank you for joining us for this morning's forum, which is called From Ethics to Logistics, What Ohio's Policymakers Need to Know About COVID-19 Vaccines. I think many, if not all of you, are already familiar with our mission. We're focused with providing independent and nonpartisan analysis needed to create evidence-informed state health policy. I want to thank our core funders who advance our mission with their steadfast investments in our work. I also want to thank our 2021 Forum Series sponsors for their generous support of our online forum series. We encourage you to tweet throughout today's webinar using the hashtag HPIO Forum. And if you have questions for the presenters, please type them in the question box and we'll take them as time permits. We're almost 1 year into an unprecedented global pandemic. The long-term impact of the virus on premature death and its disparate impact on older adults, people who live in congregate settings, and communities of color is troubling and will take time to fully evaluate. Addressing the pandemic's many economic, social, and health consequences requires accurate data, action based on the best available research evidence, and strong collaboration among state and local level partners in both the public and the private sectors. COVID-19 will remain a threat until the vaccine is widely available, accessible, and administered. In December of 2020, Ohio received its first doses of the COVID-19 vaccine and began to roll out a plan to vaccinate people identified as high risk. Since then, over 1.5 million Ohioans have received at least one dose of the vaccine. This is a cause for tremendous optimism and hope as we know that the vaccine will save lives and change the course of the pandemic. Today, our speakers are going to discuss the challenges that states face in tracking vaccines and ensuring equitable access. They're also going to talk about what other states are doing to improve vaccination rates and reach disadvantaged communities and at-risk groups. We're going to hear about how local health departments in Ohio are responding to the challenge of vaccine administration and the legal and ethical considerations for the COVID-19 vaccine. And then last, we'll explore strategies to overcome vaccine hesitancy, combat misinformation, and increase public trust. Today's slides and other related resources will be available at the HPIO website and can be found by clicking the Events tab. So now I'm going to introduce our first speaker, Rachana Pradhan, who is a national correspondent with Kaiser Health News. Welcome, Rachana.
Thank you so much for having me. Thanks, Amy, for the nice introduction. So I'm excited to be with you all today, and I'm going to just start with providing a sort of high-level overview of where with vaccinations and get into some of the topics myself and my colleagues at KHN have dug into, which goes, runs the gamut from supply issues to distribution and equity concerns. So I will start with that. So there we go. So as a journalist, I have to apologize because this is already out of date based on the CDC's website this morning. But yesterday, when I was pulling the latest numbers, just wanted to kind of provide an overview of where we are right now when it comes to vaccination distribution and administrations across the country. So as you can see, per the CDC's data as of February 23rd, we have delivered over 82 million, vaccines nationwide. Of those, the number that have been administered is 65 million. Now those account for both first and second doses. So I think overall right now it seems as though about 6 to 7% of the overall US population has been fully vaccinated. So, clearly making some headway, but quite a ways to go. Although we can get into this, the vaccine supply is expected to tick up kind of rapidly in the next several weeks. So the states, have been meaning to dig into this more, but the states that have the highest vaccination rates as far as getting their adults immunized, you can see here there are about 6 of them that lead the pack, and vary as far as population density and also size overall. But I think a few things stand out to me from what I've picked up about why these states are doing relatively well. Some is because a state like Connecticut is pretty dense, and also you don't have to travel very far sometimes to get a vaccine. But states like West Virginia, I think this has been nationally covered across the country, has done a particularly good job with vaccinating inside of its nursing homes, both residents and staff. And so that has really helped them get some success. So overall, yesterday, the Biden administration, their COVID response team, said that we are going to start seeing a big jump in weekly allocations. 14.5 million doses are going to be shipped this week. And that, of course, does not yet account for the Johnson & Johnson single dose vaccine, which honestly we could see as early as tomorrow getting FDA emergency use authorization. And immediately following that, the company says that 4 million doses will be shipped immediately. So we could start seeing some of that show up in the numbers next week. I will move on here. So what we know right now, state, of course, vaccination plans and where they are in the process for opening up, how beyond our most vulnerable populations, such as people inside of long-term care facilities and, of course, our healthcare workers, we are starting to see more and more states starting to open up vaccinations to people with high-risk medical conditions. How broad or narrow that is, of course, varies widely. Just to throw out a couple of examples, Massachusetts is a state, for example, that has had, they just began to open up to high-risk medical conditions, but you need to have at least 2 comorbidities to have started to qualify. I think it was beginning last week, and they will eventually sort of broaden that to include a single comorbidity, but right now they're starting with that. They also all have varying degrees of sort of self-attestation and or verifying whether you actually have a condition, which of course will affect access down the road. Overall, and this probably will not come as much of a surprise to most of you listening, but early data that we have is showing some pretty jarring equity challenges we are seeing, and this is from reporting from my colleagues and other places, both at KHN also and my policy colleagues at the Kaiser Family Foundation. We are seeing much lower vaccination rates among Black Americans and whites based on sort of our initial analysis looking at healthcare workers. And we will, I think the CDC also, based on the limited data they have, are showing that whites are getting vaccinated at much higher rates than Black residents. So that's definitely an issue that will need to be addressed more readily in the coming weeks if we hope to achieve the levels of herd immunity that we want. Interestingly, I've started to see this maybe last week and this week, which is that there are some states that are beginning to institute sort of an age-based system as opposed to sort of looking at should we open up vaccinations to people who might have higher risk of severe health outcomes if they were to get COVID-19. Connecticut and Utah, interestingly, are kind of moving in a different direction, and they're going to go purely by age. So I think the overall lesson of this is it seems like, states, there isn't just one way to do this. It's really all over the place, as are, how you can even get an appointment these days. So um, overall, this is something that we've dug into a lot at KHN in our reporting. We can sort of draw some conclusions or maybe some early sort of analyses based on what the data shows us so far, but we also don't know an incredible amount of information, particularly on race and ethnicity. The table is a little small here, but hopefully you can see this. I pulled this from the CDC's MMWR report that came out a couple of weeks ago at this point in early February, and it was examining the first month of vaccinations in the US and sort of early signs of, based on demographics, of who was getting vaccinated. If you can see, we have pretty good age information. Almost 100% of the vaccine records that the CDC has included age information of those people who got vaccines. But race and ethnicity is much, much worse. Almost half of the administration records that the CDC has are missing race and ethnicity data. So clearly, of course, it's hard to figure out where problems are if we can't get comprehensive information on people's race and ethnicity. There's also, and this is something that we recently dug into here, there's very inconsistent reporting of occupations, even though, as you all know, vaccine administrations, the way that people became eligible largely in the beginning was because on their profession or place of work. The CDC does not require occupation to be reported to them, even though there are a whole other host of demographic information and data points that are required. And states, there are some states that are, Ohio being among them, which we are very appreciative of over here, that does require providers administering vaccines to classify target population and occupational group of every vaccine recipient. And that will, of course, help inform when the state should begin to perhaps open up to broader population groups based on what they are seeing. So why do we have such a difficult time tracking vaccines that have been given? Well, we have the CDC, of course, and the federal government gets data from probably thousands, if not tens of thousands of systems, that have varying degrees of connectivity with each other. And it's extremely complex and disjointed that, where the CDC is getting their information from, of course, because we do not have a national immunization registry. So this next slide, I think, sort of underscores it. When my colleague Fred Schulte and I were working on a recent story about why it's so difficult to get comprehensive data, I was talking to the CDC, and they flagged, of course, their vaccine administration data agreement, which every jurisdiction has to sign in order to send the information that the CDC wants on vaccinations. And it included this diagram, which it's a little maybe difficult to see it from small, but you can just see how the yellow box there is our IISs, which are state immunization registries, or county. Oftentimes we have 64 different IIS systems in this country for every single state, the District of Columbia, territories, and also a handful of large sort of US cities. So those are probably the most comprehensive, or sort of the backbone of where we get our vaccine data from, but they all have varying degrees of sophistication. And on top of that, not everything connects to state IIS registries. There's a separate portal that the CDC set up just for COVID-19 to track vaccination data. That's called VAMS, and it's been pretty widely reported that VAMS has had significant issues, and at this point, not many jurisdictions are even using VAMS because of the problems. So we have this extremely complex data architecture system that sends all this information to the CDC about vaccinations, but of course, there are lots of missteps perhaps in collecting information. And the flip side, of course, is we all want better data, But there is, I think, some concern, and we've also heard this from public health officials, which is if you are too stringent about the information sharing and what someone provides to you when they are getting a vaccine, you don't want to be so demanding that you potentially sacrifice a person getting a vaccination to begin with. Particularly, I think on race and ethnicity, sometimes those can be sensitive questions, and just to get that information, do you want to press so hard that you might run the risk that that person just doesn't get a shot because maybe the comfort level isn't there? And so, if the overall goal, of course, is to get as many Americans vaccinated as possible, it's a delicate balance between those two things. So, so I don't want to talk for too long. I want to get to all of your guys' questions if you have any. So, given the data challenges and what we do know so far, what can counties, states, local community groups, hospitals, and other healthcare providers do to try to improve the rates of vaccinations? And I think there are a couple of things just from the get-go that will begin to help actually improve the rates of vaccinations, which have been going up on a weekly basis to date. So one big thing, and this is just sort of a, not so much from a particularly a policy-making side, but vaccine storage requirements, I think, are set to change in the coming weeks, both because the Johnson & Johnson single shot is not as sort of, the storage requirements are not so difficult. It's on par with the Moderna vaccine, the mRNA vaccine. So I think just having a little bit of ease in like how these vaccines can be transported and stored will help. The second big thing is that recently Pfizer, which had been saying that you need ultra cold storage, is probably one of the most feasible ways to store that vaccine and to give it out. And of course, that sort of limited where that vaccine could be distributed to places that have the ability to either who already had ultra cold storage facilities or managed to procure freezers. They have said that they are going to loosen, or they are planning to loosen the temperature requirements, because it appears that the mRNA vaccine from that company is also able to maintain its shelf life at slightly warmer temperatures along the lines of the Moderna vaccine. So if that ends up happening, I think it will help with vaccinations just naturally, because you can distribute the Pfizer vaccine more widely. And of course, we are supposed to have 300 million doses of Pfizer, if everything goes right, by July. So that's one thing that will help, I think, just naturally. One big thing that, of course, we've seen a shift in strategy on vaccine distribution since the Biden administration took office in January. One of the big things I think that they have started to do that was not there before, and this is also the goal is to improve equity, is shipping vaccines directly to community health centers, which of course, as you all know, are treat low-income populations all over the country. So they have started with at least one community health center in each state, and the goal is to get to 250 nationwide. And so once those start to pick up, I think we will hopefully start to see a little more vaccination uptake among sort of low-income and especially minority groups. Mass vaccination clinics, as we start getting into maybe more of an open season as far as the populations that qualify. I, of course, am in the Washington, D.C. metro area in Virginia, and we are starting to, even in my state, starting to see a greater shift toward vaccine clinics, and oftentimes those are set up in sort of lower income, non-white neighborhoods, and so designed to get, again, like non-white populations vaccinated who may not have the resources to get it elsewhere. The fourth thing I just wanted to flag, because this is of particular interest to me, and we plan to do more work on this at KHN. I've been talking to folks about language access issues, and also just not just translations that might be available to people who do not speak English as their first language, but culturally appropriate and accessible materials to help encourage vaccinations among non-white populations. There's some really interesting work going on with community organizations in health centers. The Morehouse School of Medicine in Georgia has partnered to do an initiative that is supposed to help vaccinate various demographics, and part of that is also providing materials in accessible, I think it's more than 30 languages, which I think is really interesting. And so if we start to see more movement in that direction, I think we will potentially start to see a shift in resolving some of these equity challenges that have come to the fore initially. So with that, I know that was kind of a broad overview of where we are at, and I'd be happy to take your questions.
Great, thank you. Please, a reminder to everyone to either type your question in the questions box, or you can raise your hand and we can unmute you so that you can ask your question out loud.
Hey, Amy, I'm not seeing any questions right now. Thank you so much, Rachana, for your presentation. If we see any pop in for you, we'll ask those after the next presentation.
Okay, great.
Thank you. Thank you so much, Rachana.
Thank you.
All right. Well, next up, we have Dr. Mashiko Roberts. She is the Health Commissioner at Columbus Public Health. Thank you for joining us, Dr. Roberts. Welcome. We look forward to hearing your update. Oh, shoot. Dr. Roberts, we can't hear you. This sort of feels like Friday the 13th, even though it's just Thursday, February 25th. If you frequent our forums, you know that this rarely happens, if ever, on our forums. So we're just having a day here.
And Dr. Roberts, you may just have to switch your audio option for us to hear you. Make sure that it's picking up from your computer.
Alana, could Dr. Roberts call on her phone?
She's doing it now.
Okay.
So Dr. Roberts, just make sure you put in your audio pen so that we can hear you.
Can you hear me now?
We can.
Great. I'm sorry about that. Well, good afternoon, or I guess it's still morning. So good morning, everyone, at least those of you who are in the Ohio area and the East Coast. Wanted to share some information about what we're doing here in Ohio and specifically at Columbus to help us with our vaccine distribution. I can share with you that even though we have vaccines, which is a great tool in our toolbox, we still have to continue to remember to utilize all of the other public health measures that we put in place thus far during this pandemic. So we still need to wear our masks. We still need to practice social distancing. We still need to wash our hands. We need to stay home if we're sick. And then when it is your turn to get the vaccine, I strongly encourage you to consider rolling up your sleeve and getting vaccinated, not only to protect you, but also to protect your community. So let me tell you a little bit about Ohio's phased approach to providing the vaccine. And do I do the slides? Yep, there we go. Thank you. So Ohio has a phased approach for the vaccines, and some of this is driven by what the CDC recommended in terms of the distribution of the vaccine. But some of it was made specifically for Ohio based on who we saw dying in Ohio and who we saw having the most severe cases from COVID-19. So we have it listed in 4 different phases. Obviously, we're in phase 1 right now because vaccine supply is very limited. And just to give you an idea, here in Franklin County, we have a population of about 1.3 million individuals. Those of you who live in Columbus know we have 4 hospital systems. And collectively, between the health departments, the hospitals, and our pharmacy and FQHC providers, we're getting anywhere between 10 to 15,000 doses of this vaccine every week, just here in Franklin County. Again, we've got a population, though, of 1.3 million. So it just puts it in perspective that the vaccine supply is still very limited. So that's why we have created this phased approach. The state has created this, and as a vaccine provider, like Columbus Public Health is, we are obligated to follow this phased approach. So we're in phase 1. We hope as vaccine supply increases, we will eventually move to phase 2. I'm optimistic that we'll see phase 2 happening sometime in April. And then when vaccine is widely available, we'll be in phase 3 and 4. And I'm optimistic that we'll see that in the summer of this year. So eventually every adult will be able to get the vaccine, and eventually the vaccine will be available for our pediatric population as well. So let's talk a little more about this vaccine schedule that we have. As I said, the Ohio Department of Health sets the guidelines for who should be vaccinated in which tier, which phase. Vaccine supply continues to be limited. Now we're in phase tier 1B. So phase 1B is really when we focus on those who are over 65. We focus on the staff who work in K through 12 schools. So it can be teachers, bus drivers, cafeteria workers, janitors, anyone who could be around the students in a building or on a bus. They are in phase 1B. And also included in phase 1B are individuals with specific medical conditions. Most of these are medical conditions that they were born with, and or they have to be severe enough to have caused hospitalization in the last year. So to give you some examples, sickle cell anemia is a criteria. Some of our metabolic diseases are a criteria. Type 1 diabetes is a criteria, but you have to have been hospitalized within the last year. So not everyone with diabetes, just those with type 1 diabetes. So if you live in the Columbus or Worthington area, this is how we ask you to get registered if you meet the criteria for vaccine. You can go online at columbus.gov/coronavirus and look for our link to register for a vaccine, or you can call us at 614-645-1519. We are doing second doses as well, and at this point, as effective this week, when you get your first appointment and you come get vaccinated, we will give you your second dose appointment at that time. If you want to see a full list of all vaccine providers, not only in Franklin County, but all over the state of Ohio, I encourage you to go to vaccine.coronavirus.ohio.gov. So let me tell you, our major operation for providing vaccines at Columbus Public Health is at the fairgrounds, at the Celeste Center to be specific. It's a drive-through clinic, so literally you have to be registered, but you just drive up. You don't have to get out of the car whatsoever. To date, we've given over 38,000 vaccines at collectively through the Celeste Center, as well as some of we have a mobile team that's going out in the community. Of those 30, this slide says 36,975. My slide says 38,000. But of those approximately 38,000 individuals, we have given, most of them have been first doses, as you can see, about 25,000, and several, 12,000 almost, have been second doses that we completely finished that vaccine series. So that's really good news that we have close to 12,000 just that we have vaccinated in our community that have are pretty much fully protected from COVID-19. I would be remiss, and I'll take the next slide, I would be remiss if I didn't talk about the disparities that we've acknowledged we've seen during this pandemic. So we know that Black and Brown individuals have been disproportionately impacted by COVID-19. We've seen that not only in the number of cases, the number of hospitalizations, and the number of deaths. Yet, when we look at our vaccine rates, only about 4% of those vaccinated have been Black. What we also have noticed most recently is that many people in our Black and Brown community have been leaving the race field vacant or saying unknown. And you heard a little bit about this in the previous presenter. That's a problem. We're not getting good data despite the many efforts that we're making here at Columbus Public Health and other places. So there's a few reasons for why either they're not getting vaccinated, or if they are getting vaccinated, they're choosing not to identify their race. A lot has to do with mistrust. They are not trustful of this vaccine, the rapid process that it got on the market. They don't like the name that Operation Warp Speed that the government gave. So there's a lot of mistrust. They're concerned that if they do identify themselves as Black when they register, they might be the first people to be canceled. If there's limited vaccine supply, they might get a different vaccine or a less effective vaccine. So there's a lot of mistrust, a lot of misinformation there. Then there's access issues. We know that most providers have been using some type of web-based approach to inform people of how to register or that they're eligible to register. There is a digital divide in our country and right here in Columbus. And so many of our minority population don't have access to that information. Some of our hospital systems are doing a great job by pushing out the information to their patients who are eligible, saying you're now eligible for the vaccine through their electronic medical record. But many in our minority community or in our low-income community just are not using those resources the way others are. So access is a problem. And then we can't, dismiss the fact that there's been many historical reasons that have made minorities more reluctant to participate in healthcare, new healthcare, and healthcare that's delivered by the government. So we could talk about the Tuskegee incident. We could talk about Henrietta Lacks and how she and her family were treated. But I also remind people, we could also just talk about the last time a Black and Brown person sought medical attention and how they felt they were treated, and they might not have been treated in the manner in which they felt they should have. So vaccine hesitancy is real, and we really must acknowledge it and ask individuals, why are you reluctant, and try to address their concerns, their questions, one person at a time. I'll take the next slide. As a result of this disparities, not only with cases, but also with individuals coming to get vaccinated, Columbus Public Health has created a vaccine equity priority plan. It's a three-phased approach, or a three-prong approach, I guess is the best way to say it. One is, how do we increase access? 2, remove barriers. And then 3, increase communication and information out there. So increasing access, I have set aside, or I've told my team to set aside a minimum of 20% of the vaccine supply we get every single week for our vulnerable populations. We do our best to collect race information, and we're always revisiting, honing it down. How can we ask the question better? How can we make sure we get real, accurate information? We just started last week hosting a weekly opportunity vaccine clinic for individuals who live in our opportunity neighborhoods. These are neighborhoods that have low income, very diverse, low access to health care, and transportation issues. We also, when we think about our mobile team going out into the community, we put addresses into CDC's Social Vulnerability Index, which again looks at income, race, medical conditions, transportation. Really those social determinants of health is what determines the CDC's Social Vulnerability Index, as well as the neighborhoods that we invite to our opportunity clinic. We're removing the barriers. We do have a mobile team that goes out into the community. I was just at one this morning on the south side. We also realize that not everyone has the internet, so we've made sure that people have the ability to register online. By phone, which is an important thing, particularly for our senior population. We know that they are much more comfortable picking up a phone and talking to someone than doing anything online or through the internet. And then I'll take the next slide. We're really in the process of launching a pretty robust informing and engaging our vulnerable communities. So we're working with our community partners, whether it be based on race, based on income, homelessness. We're working with many agencies across the community to help us connect to the vulnerable population. We're having conversations with a diverse group of individuals that we know have some influence in the minority community. On Monday, I had a conversation with barbers and beauticians because we know that particularly for the African American community, they spend time getting their hair done and they trust the person who does their hair. So really wanting to educate those individuals about the vaccine and about the safety of vaccines so they can be a champion or ambassador for us. We are partnering with the Department of Neighborhoods at the City of Columbus to help us engage the community and provide some boots on the ground. You know, we're just going kind of old school on this. We realize that the media, social media, radio might not always work for some individuals, so we need to be right there, even going door to door if need be. And starting this week, we're launching a community multimedia campaign with special focus on the underserved communities. And there's a special tonight for you that are local on Channel 10 that I encourage you to watch at 7 p.m. So let me tell you a little more about this opportunity clinic that I mentioned. Last week was our first. We're doing it again this week. We're targeting those at-risk neighborhoods. These are the same opportunity neighborhoods where we've seen high infant mortality rate, high crime, high unemployment, lower educational attainment. You see the zip codes listed here. So again, we're really focused on these zip codes. So this is who we've invited to the Opportunity Clinic. So if you live in one of these zip codes and you meet the state's criteria, then you can be vaccinated. It's here at Columbus Public Health. We thought that would reduce the barriers because we know not everyone has transportation or a car that can go through our drive-through clinic at the fairgrounds. So this way, if people can want to get dropped off, if they want to take the bus, they can come to the health department. We've created a dedicated phone number just for this opportunity clinic so they get more of a hands-on approach. And obviously, transportation is available to our seniors who qualify for this clinic working through the county, and we make sure they have that information. If individuals are eligible for the opportunity clinic and call us, and we determine that they might have some mobility challenges, like, you know, they walk with a walker or they use a wheelchair, we ask them, would it be easier for you to go to the fairgrounds? And if so, we make arrangements to get those individuals vaccinated at the fairgrounds. And then I think that's it, but I'm happy to answer any questions anyone might have of me this afternoon.
Great, thank you, Dr. Roberts. This is Amy Rowley McGee, and I'm just going to look at the I'm going to look at the question box here and see what questions we have coming in. Oh, so someone asked, what was used to create phone numbers and who is providing the additional transportation? So I don't
understand the first part of the question.
I don't either.
So who's providing the transportation? That's an easy one. The transportation is being provided by the County Department of Aging, and so they are helping anyone, not just at our opportunity clinic. So anyone who's eligible get to a vaccine clinic, and you can reach out to them by calling them at 614-525-6200.
Great, thank you. And the mobile units, where are those going and where are they stationed? Are they going to individual homes or to a central spot in a community?
Right, so at this point in time, our mobile units are going to very specific locations or agencies, and we're caring for the individuals who work or live there. So for example, this morning, we were at Community Housing Network's Parsons location, and we vaccinated the individuals who live there and the staff that work there. So it's not necessarily open to the public. We've gone to the YWCA's family shelter and done the same thing. We do plan on opening some what we call community-based or really place-based approaches that would be open to the neighborhood and the community. We haven't started that yet, but we will be doing that starting the month of March. Another tool that we have in our toolbox that I encourage individuals who have phones and want to be able to do this is we now have a text program, TEXT. So if you want to receive real-time information about when vaccine is available by Columbus Public Health, I encourage you to text the message VAX, V-A-X, CBUS, C-B-U-S, to the phone number 888-777. So 3837. The message is VAX, V-A-X, CBUS, C-B-U-S. And when we open our registration, like tomorrow morning, we're going to open our registration again for next week for those who are 65 and older and those who have qualifying medical conditions. If you meet that criteria, you'll forget it. If you sign up for the text, you'll get a text saying it's open. It'll tell you who's eligible, and it'll tell you to go to our website. You go to our website and you'll register. So we will be pushing that type of information out to individuals. We also ask for your zip code so that when we do place-based approach and you live in that zip code, you would get a message saying Columbus Public Health is going to be in your neighborhood or near you on X date. If you're interested in registering for the clinic, go to our website. So that's a tool that we just launched last week, and I'm pretty excited about it.
Wonderful. And one last question. We've been tracking the number of unknowns for race and ethnicity, not only in vaccinations, but also across cases and hospitalizations and deaths. But as it pertains directly to vaccinations, have you or your team learned anything over the years of administering just vaccinations in general regarding best practices for how to ask questions related to race and ethnicity? For example, is it better to hand someone a form and ask them to complete it, or is it better to have some words that accompany that in order to explain why the information is being collected and increase the comfort level with providing the information?
Yeah, that's a great question, Amy. And I know one of the recommendations we got last week from Swellen Bennett, who I'm sure you know over our Center for Public Health Innovation, was when we're registering individuals by phone, we should not give them a menu of options for their race. We should just say, what race do you identify with, and let them answer. Because when you do give people multiple choices, then they are likely to pick unknown or other or something that doesn't really identify their race. So we have moved to that system. But when you do fill it out, like when you fill it out online, you do get the menu of options. And we're trying to add some language there that really explains and encourages people to answer that question honestly.
Yeah, I know I registered a couple of people for local pharmacies vaccine availability, and the question wasn't even asked to. So that was troubling, because I think we need to make sure that we're always asking. That decline to respond is always an option, and that we're asking it in the most effective and respectful way. Because without the information, we won't be able to know the extent to which we're truly advancing equity through our vaccination efforts.
Absolutely, and we've expressed that to the state, that not all vaccine providers are created equally, and they all need to ask those pertinent questions.
Yes. Well, thank you so much, Dr. Roberts, for spending some time with us. We very much appreciate all that you've done here in the Central Ohio area, but also that all your colleagues, health commissioners throughout the state, and your teams have done. I think you don't get thanked enough. We very much appreciate the long hours, the hard work in a very challenging environment, and your efforts to improve public health.
I appreciate that, Amy. Thank you. And I will definitely pass that on to my staff. They've been rock stars. I'm so proud of them.
Okay. Thank you. Have a good day.
Thanks. You too. Bye-bye.
All right. Well, we're gonna move right on to our next presenter. And we'd like to encourage you, though, since we've been sitting for a bit, just to stand up at your desk or wherever you are and stretch a little bit, walk in place, do something to exercise your mind and your body for a few minutes. So next up on our agenda is Debbie Kaminer. Debbie is a professor in the Department of Law at the Zicklin School of Business at Baruch College, which is a part of the City University of New York system. So she's going to talk about the legal and ethical considerations for the COVID-19 vaccine. Welcome, Debbie.
Hi, Amy. Thank you so much. It's really a pleasure to be here today, and I want to thank the Health Policy Institute for arranging this forum. Now, many of the other speakers are talking about the incredibly important issues surrounding equity in vaccine distribution, and currently demand for vaccine outweighs supply, and that is where much of the focus is. I am going to be talking about something a little bit different, which is what is it that government and businesses can do to ensure enough Americans are vaccinated that we reach herd immunity once there is sufficient supply of vaccine, as well as adequate access and distribution. Hopefully that will occur by this summer. Now, as Dr. Roberts mentioned, one of the most important issues going on right now is that many Americans are not only vaccine hesitant in general, vaccine hesitancy was a problem prior to the pandemic, but are specifically concerned about the safety of the COVID-19 vaccine. Earlier this month, a CDC report came out that said less than half of Americans, according to a poll, would be willing to either absolutely be vaccinated or be likely to be vaccinated. And 32% of Americans said they had absolutely no intention of being vaccinated. So what I'm going to be talking about is what is it that government and private businesses can do legally as well as ethically, either to mandate vaccines or encourage vaccines so we are able to reach herd immunity. A lot of the screen isn't, okay. So what is it that we could do to reach herd immunity? And specifically, I'm going to be discussing 3 things that we could do. And the first are government mandates or government laws, and these include both very broad laws as well as more targeted laws. The second are what private businesses can do, and this includes what private businesses can require of their customers as well as of their employees. And finally, I'm going to briefly discuss some of the behavioral economics research in terms of how people can either be nudged or encouraged to be vaccinated. So I'm going to start off by talking about, about the broad-based government mandates. And one thing that many people are very surprised to learn is that states have extraordinarily broad legal authority to mandate vaccination laws. And this stems from a 1905 landmark United States Supreme Court case called Jacobson versus Massachusetts, where the United States Supreme Court upheld the constitutionality of a state criminal law that required all adult inhabitants of Cambridge, Massachusetts to get a smallpox vaccine. And Mr. Jacobson had argued that this mandatory policy violated his liberty interests under the United States Constitution, but the Supreme Court disagreed. And essentially what the Supreme Court said is that states have what are known as police powers, and this includes the right to pass laws that are necessary to protect public health and safety. So it wasn't that Mr. Jacobson did not have a liberty right, he did, but it was not absolute, and that this law was actually necessary to promote public health and safety. Now, this is a very old case. It is from 1905. It is still what's known as good law. It was cited as recently as this past summer of 2020 by the United States Supreme Court. Now, the one thing I do want to emphasize is these broad-based mandates are mandatory vaccination laws. They are not forced vaccination. It is not that anyone from government has the right to force you to be vaccinated. That would certainly be unconstitutional. in these cases, we were talking about a penalty that was a fine. These types of broad-based mandates don't occur that often, but I'm actually from New York, and there was one in April of 2019 where there was a measles outbreak in New York City, and the New York City Health Commissioner issued an emergency order that anyone who lived, worked, or went to school in one of 4 zip codes had to be vaccinated against measles, and the penalty for non-compliance was a $1,000 fine. Now, most of these, what was interesting is most of these zip codes were comprised of members of the Orthodox Jewish community, and parents of children attending school in the area challenged this order, saying that it was unconstitutional religious discrimination, and they actually lost that case. Now, the problem with these kinds of broad mandates, and this was seen with the New York measles vaccine case, is that people find them to be very coercive. There is concern that wealthy individuals can simply buy their way out of vaccination, what leads to equity issues. They're controversial, they're heavy-handed. If you think about the United States, where even mask mandates are divisive and can lead to conflict, I think this type of a broad-based mandate, while legally permissible, is not a good idea. I think it will escalate tensions. I think it will increase mistrust of government. And I do not think states should adopt these kinds of policies, nor do I think they will. Now, and I'm having a little bit of trouble getting to the next slide. Okay, so the next thing, which is a less intrusive approach, and this is an interesting approach for state governments to think about, is to require COVID-19 vaccination only for certain segments of the population. So currently, all 50 states require some compulsory vaccination for children attending daycare or K-12 schools. Some states also require vaccination for healthcare workers or for college students or for nursing homes. Usually it's the people who are most vulnerable, most likely to get ill. And one of the most controversial issues with these targeted government mandates that only apply to certain segments of the population have ended up being religious and philosophical exemptions. So currently 45 out of the 50 states have some type of religious or philosophical exemption. Currently, 2 states that have removed their exemptions are New York and California. When California removed its religious exemption, it did end up increasing vaccination rates in the public schools. Removing religious exemptions is politically controversial, but under federal law, it is constitutional to remove these exemptions. And the reason for this is what the Free Exercise Clause of the First Amendment to the Constitution says, is that if a law is what is known as a neutral law of general applicability, which means that the purpose in passing the law is not to target any religion and it doesn't single out any religion, it will be constitutional. It will not violate the Free Exercise Clause, even if religion ends up being burdened by it. So a general law, for example, that all school children or all teachers need to be vaccinated against COVID-19 would not violate the United States Constitution. Now, there are some states that give additional protection to the free exercise of religion, and Ohio is one of these states. And essentially in these states, a balancing test is used, and the issue then becomes whether mandatory vaccination is the least restrictive way of furthering the compelling interest of reaching herd immunity. So in a nutshell, what you do is you balance the rights of a religious individual against the state's right in ending the pandemic. And this ends up being a very, very fact-specific determination. So when you ask yourself, okay, so what types of businesses, where should the government actually mandate a COVID-19 vaccine? I think that what would make sense is to mandate vaccination against those most at risk, as well as people who are most likely to spread the disease. And again, remember that this is already a system that is in place in all 50 states. So perhaps cover school children once a vaccine is approved for children, maybe college students living in dorms, healthcare employees, perhaps some kind of vaccination passport should be required, proof of vaccination to go to a large public event such as a concert, a sporting event, a gym, a bar. Now, one interesting country to look at is Israel, which is the country with the highest vaccination rate in the world. And they're actually starting to do this, where people get a certificate of vaccination that they would need to go to a restaurant, a bar, a gym, another type of crowded public venue. Now, certainly you would have to work out the equity issues to do this. Certainly you could only do this once the vaccine is widely available. There are not distribution problems. People have the ability to get the vaccine. This is not something I am saying we should do immediately. It is just an approach I think it is interesting for government to look at. Okay, so that is what government can do. So the next thing I want to look at is, okay, what is it that private businesses can do? And private businesses have the power to mandate vaccination, either or both, for their employees and their customers. Now, there is a really, really important distinction I want to make between private business mandates and government mandates. What I am referring to with a private business mandate is there is a business in a state which does not mandate, for example, a COVID-19 vaccine, and that business decides it still wants to mandate vaccination. So an analogy would be that in some states, not all states, but in some states, there is a state law that healthcare workers must be vaccinated against influenza. In other states, there is no such law, but individual hospitals decide on their own they will require their employees to be vaccinated against influenza. Now, private businesses, unlike government, are not subject to the Constitution, either the federal Constitution or state constitutions. So the Constitution is simply not applicable with these private business mandates. Additionally, when it is a business mandating vaccination, as opposed to the government, say, telling all school children they need to be vaccinated, you could come up with arguments as to why this should be less controversial, and certainly this is beyond the scope of this forum, but the whole idea that libertarians are very opposed to government mandates, this should just not be an issue at all when you are talking about what a private business does. Now, I want to say a few words, and this is not moving, about private businesses, specifically with employees. And the reason I want to say a few words specifically about employees is in December, the Equal Employment Opportunity Commission, which is the EEOC, that's the body responsible for enforcing federal anti-discrimination laws, issued guidelines that stated employers do have the right to mandate COVID-19 vaccines. They do have the right to mandate these vaccines, but they are subject to anti-discrimination laws. And essentially, I mean, basically with this, I don't have time to go into all the details of the anti-discrimination laws. The most important types of discrimination in these kinds of situations in previous vaccine mandates have been religious and disability discrimination. So the biggest question is, if an employer mandates vaccination, when is it that employers need to provide an exemption for a religious employee or for an employee with a disability? Now, another potential really interesting issue is pregnancy discrimination. And just last week, there was a case in New York where a waitress was fired for refusing to get the COVID-19 vaccine because she was trying to get pregnant and she wanted to research its impact on fertility. Now, in New York, waitresses are, permitted to be vaccinated at that point. So the restaurant was able to have this type of a mandate. But this is an interesting issue I think we're going to see a lot more of. But essentially with these anti-discrimination laws, when you are dealing with a private business requiring vaccination, what the courts do is they apply a balancing test. And essentially, anti-discrimination laws require courts to ask whether an employer will suffer an undue hardship if they provide a religious or disabled employee with an exemption from vaccination, and they must provide the exemption unless they will suffer an undue hardship. And this ends up being a very fact-specific type of determination. So at the bottom here, I have pictures of a gym, of a restaurant, of a hospital. These are the types of businesses where an employer might be found to suffer an undue hardship if they refuse to accommodate an employee who has a religious objection to vaccination. Additionally, you could argue that in consumer-based businesses such as restaurants, customers might be less likely to frequent the business. But if you are dealing with, for example, an employee working fully remotely, it's highly unlikely an employer would suffer an undue hardship if they refuse to exempt an employee from their mandatory vaccination policies. Now, there is one really interesting wild card issue, and that is that some states, including Ohio, have introduced legislation that employers cannot discriminate against employees who are unvaccinated. So essentially what these states are saying is, just like you cannot discriminate based on race or based on sex, you also cannot discriminate against the unvaccinated. The unvaccinated are a protected category. Now, to the best of my knowledge, this legislation has not yet passed in states, but I find it a rather troubling approach, because it is one thing for a state to say, we will not mandate vaccination. It is another thing for a state to say, no employer may mandate vaccination ever. And then the final thing that I want to talk about are nudging or encouraging people to be vaccinated, and the incredible importance of educating the public on the safety and efficacy of the COVID-19 vaccine, which are all issues that Dr. Roberts had spoken about. Messaging matters very, very much. Government needs to be creative in recruiting whoever it is that a particular community will listen to and trust. This could include religious leaders, social media influencers, celebrities, athletes. Dr. Roberts mentioned barbers and beauticians. Two specific examples I want to give, two historical examples. One, that is a picture of Elvis Presley getting his polio vaccine live on the Ed Sullivan Show. After he did that, within a period of 6 months, teen vaccination rates increased from 0.6% to over 80%. During the measles outbreak that I had mentioned that impact the Orthodox Jewish community, it was the Orthodox Jewish Nurses Association that was really on the forefront of educating the community on the safety and efficacy of vaccination. And then finally, I just want to quickly mention some studies which have shown low cost, non-coercive, and effective steps employers can take. Okay, 3 good things: effective, low cost, and non-coercive. So one study was done at Rutgers University where some employees were sent an email that automatically scheduled them for the influenza vaccine, and they were told they had the option of opting out of the vaccine. Other employees got an email that permitted them to opt into the vaccine. Simply scheduling an employee and telling them they could opt out, as opposed to letting an employee know they could opt in, increased vaccination rates by 36%. This is something employers should consider doing with the COVID-19 vaccine. In another study, a large utility firm sent employees an informational mailer that included the date and the time of a workplace vaccination clinic. Half of the employees had a mailer that included a little reminder, please write down your chosen date and time. The others had no such reminder. Simply including that reminder increased vaccination rates by 12% over those who did not get the reminder. So I think realistically, the best way to ensure we reach herd immunity, once there is a sufficient supply and we have adequate access and distribution and are addressing the equity issues, is some type of targeted government policy. For example, all school children or all teachers, once the vaccine is approved for children, along with private businesses having the right and the ability in some circumstances to mandate vaccination. And of course, the nudging and the behavioral economic approach should always be used because it is effective, low cost, and non-coercive. And I'm happy to take any questions people have.
Thank you, Debbie. Thank you for sharing your insights. We're going to move right on to Dr. Hill so that the audience has the benefit of getting to hear her remarks. We thank you so much for spending some time with us today. So, hi, Dr. Hill.
Hello.
Dr. Hill is a professor and an associate dean of clinical affairs, as well as a project director of We Care, which she'll talk about here in a second, at the University of South Florida. So welcome, and we look forward to hearing what you have to share today.
Well, good afternoon, everyone. And I again want to applaud the organizers for today's event. It's amazing how the previous speakers have addressed some of the things that I'm going to talk about, but I'm excited about being the last one today so I can also include some information that I think will be very important. as it relates to what is needed in terms of community engagement. So we'll talk a little bit about effective communication strategies. So as was mentioned, I'm the project director for We Care, and I think I'm going to need some assistance with my slides. But uh, as we move on today, I think I'd like to just kind of tell you a little bit about We Care, and in the next slide, you'll be able to appreciate that We Care actually stands for Work Group Enhancing Community Advocacy and Research Engagement. And in the upper left, or at least my left, you see Dr. Kevin Sneed, who's the dean of the college, and this is the brainchild of his as a spinoff from a bigger grant that we had with Moffitt Cancer Center and some other departments at the university. And at that time, there was a health equity center that set out to address health disparities with patients predominantly who had cancers. And once the funding ran out, he birthed We Care as an attempt to still engage with the community. And so we've partnered with other community groups represented by Dr. Deborah Austin, and then we work with our community liaison for the college, Mr. Hiram Green, to actually help try to close the gap of health disparity by engaging with the community, educating them, as well as empowering them with the ins and outs predominantly related to research participation and a better understanding of diseases and things that impact the community. So as we advance to the next slide, I think this is really important because our objectives through our We Care efforts really are to bridge and break down a lot of those barriers that have already been referred to by Dr. Roberts that currently exist. And we are aware, one, being a research one institution, that communities shy away from any discussions related to research. And so our mission really is to serve as liaisons for the community and researchers to help each group kind of understand one another. And we feel that educating and empowering them in this way will really help. So in the next slide, some of the things that we have been able to successfully do particularly have allowed us to close the gaps of health disparity, because we understand, particularly as healthcare professionals first, that it is so important that we pay attention that different ethnic groups can respond differently to medications, and that as we promote research and we talk about devices and things of that nature, we need to make sure that certain groups know what to expect from products and devices before they get on the market, and we not have any horrible outcomes that we've seen in the past. And one of the things that we have embraced over the years has been a realization that people don't forget about the Tuskegee study, as Dr. Roberts already alluded to. They know about Henrietta Lacks, they know about the syphilis issues with Guatemalans and stuff. And so there's a lot of hesitancy for research. And even as we've gotten into the pandemic, even more hesitancy because of those unfortunate stories. And so we have been really working hard now collectively for over 10 years to really try to work with the research community and our Black and Brown communities to really help them. And so the COVID pandemic has created opportunities for us to further bridge that knowledge gap, not just in the spirit of research, but just certainly in helping them understand a little bit more why it is so important that they consider vaccination. So in the next slide, let's talk a little bit about what We Care is doing and how we're doing it. Well, as I mentioned, We Care has been around long before the COVID pandemic started. And we have been traditionally having these, what we call matchmaking events, where the community could come out and we would actually go to centers in some of our lower socioeconomic areas and host different things at the university, but try to go to the community and bring along researchers that had the opportunity to talk about their research projects. And we would utilize what we call the gatekeepers of said community areas to actually help with recruiting attendees, and certainly also be a part of an advisory team that would help vet the risks associated with the study. And once they would bless it, so to speak, and this is beyond what the IRB committees were doing, we found that that was a good mechanism for them to try to help trust that the researchers had good intentions for them. We also have conducted things like focus groups to better appreciate cultural and other and religious kind of philosophies about research participation and their understanding of certain diseases. And we've done a lot of work over the years with African Americans, with Hispanics, as well as Western Indians. And so that has really helped support and allowed us to craft a lot of our educational initiatives. So some of the themes with our education has been certainly cancers that affected minorities, some of our chronic diseases. My particular background clinically happens to be Alzheimer's disease, mental health, and the like. But we have hosted or continue to host those kind of workshops, making reference to current times. And so since last May, we started doing things related to COVID. And so that has been actually interesting. So I think in the next slide, I have some examples of some of the flyers that we use just kind of starting out. It might be just a little further down, but we did some research as the pandemic kind of started out. And I think Professor Kaminer kind of made reference to some of the surveys that were out from the CDC and other groups, but this one actually was a survey done early April. And it kind of just got the impression, looking at racial and income differences amongst the community, about the perception of whether or not COVID would require hospitalization, and certainly what we call spreadability of COVID. And what we were noticing was that certainly in our Black and Brown populations, there were a lot of concerns there. When we look at the socioeconomics of this, definitely it was a sign that we needed to probably start honing in on having some conversations to kind of dispel those myths. In the next slide, we also looked at other slides, and as Professor Kaminer talked about, the willingness to get the vaccine, we appreciated that back in May, people were already saying before the vaccines were available, there was a lot of hesitancy there. And what we noticed as we looked at this particular survey and then started doing surveys of our own, that there were patterns in terms of age and ethnic groups, in terms of resistance. And unfortunately, again, noticing this same pattern where the Black and Brown populations seem to be resistant. And so we were kind of curious as to the whys. Why is it that there's so much hesitancy? And what kept circling up and bubbling up, the older the individuals were, that the Tuskegee experiment made them, feel a little uncomfortable. And as was mentioned, Operation Warp Speed, the government's response early on in the pandemic, they just did not feel comfortable. So we set out to launch a educational campaign, but we also, in the next slide, looked at a survey that honed in on African Americans and their perception about how they would be treated compared to our white counterparts. And so when asked about whether or not they felt they would get the same type of treatment or be admitted to the hospital or even be offered experimental treatments, as well as being assured that they would be treated and everything would be done, to make sure that they were okay. What we found overwhelmingly is that at least 59–60% average, African Americans just felt very uncomfortable with how the healthcare system would treat them. And so this is both alarming, and unfortunately some of the social unrest that unfolded over the summer has, compounded that. But this was early on in the pandemic. And so with that, we really set out to make sure we started crafting messaging that could reach the community so we could kind of influence them and empower them with an understanding about what is needed for us to get control of the pandemic. So in the next slide, I think you can appreciate some of why we were doing this. And a lot of this is because we were hearing in the news and everywhere in the media, the risk factors that, seem to be more prevalent amongst racial and ethnic groups. So it, unfortunately, I think compounded some of the distrust that African Americans had, especially Latinos, because they felt they were being targeted, because no one was really explaining very much about out why they were at a higher risk, except there seemed to be a higher prevalence. So when you look at this slide, you'll see Native Americans, African Americans, Latinos, again, at the top of the list for risk factors. The next slide showed that these were the same groups that had a lot of the underlying conditions that unfortunately led to death and poor outcomes in these particular patients. So while New York City and places, California and others were dealing with the numbers, we still had cross sections of underrepresented minority groups who were really feeling that what they were reporting or what we found in those surveys were true. So we started out with the campaign that targeted the most affected, and then have been reaching out ever since to those. So what we did in May just was the launching of what we call the Lunch and Learn series. And so you can go in the next slide and appreciate some of the flyers that were developed to start this series. And we started out kicking it off with our dean, kind of explaining what COVID is, trying to dispel the myths early on. And I'll share with you later in an upcoming slide what that was, some of the myths that we've seen related both to the infection as well as the vaccine. But he then passed the baton to me and a colleague, and we delved into some of the mental health consequences that we've seen in present and past pandemics, because we were concerned that while the pandemic was going, our hotlines for mental health services, suicide, and all of those things were just exponentially increasing. We then passed the baton over to a group that kind of talked really about community resources that could be used to kind of provide emotional and or financial and other support to our underrepresented and minority communities, because we had a lot of people that unfortunately were getting furloughed. They, were losing their jobs altogether. We were having issues with employment. And so a lot of these things were certainly impacting outcomes, in addition to, again, all of the death and dying that was occurring with the pandemic. And last but not least, our four-part series, we talked about testing and certainly appreciating things like how it impacts pregnant women, because that question was coming up early on, because even though the data was showing that the vaccinations were being studied and all of this stuff, there were questions about whether or not those kind of individuals should be tested, if they're at higher risk, if their unborn fetus was at risk, et cetera. And so this was some of the feedback we were getting from our gatekeepers. And what we found after doing this four-part series is that we reached enough individuals just doing them virtually. We started getting a lot of calls and requests to provide more. And so we set off to do a whole lot more to kind of connect to the community. So in the next slide, I just kind of want to outline to you what we did in the spirit of virtual workshops. We not only did the standard workshop or webinar like what we're participating in today, but we got into town halls and panel discussions, dialogues and discussions where we would take smaller groups. We were getting requests for radio interviews and newspaper stories, and then had private employers who were having to make the decision about whether or not they were going to mandate quarantines and things like vaccination as we got closer to that. So we started just kind of modifying, but kind of working with different groups. And then the last 2 months, we've really been supporting a lot of vaccination events and targeting, again, some of the underserved and underrepresented minority communities, because we started paying attention to the number of people who were getting vaccinated. And in a state as large as Florida, where we have so many seniors, we're currently still in phase 1. So that meant our older community citizens who were in long-term care facilities, or our healthcare professionals who are trench level and essential workers, were the main ones who are getting access to the vaccine, and the 65 plus and older community dwelling individuals. But unfortunately, we learned early on some of the challenges associated with the process. So we started working with various community groups that we had already been inviting to a lot of our virtual workshops to try to bridge some of those problems. So on the next slide, I want to kind of get into the myths that we taught, what we kind of ran across. So as we started doing all these workshops, we started noticing some of the questions, and people started sharing, you know, what they had been hearing, what they've been listening to, some of the text messages they were getting. And common things pertaining to the virus was that it was man-made. It was nothing, you know, it was just a stronger version of the flu. You know, this is really a form of genocide. And you can contract it from things like the mail, and also a lot of paranoia, you know, was occurring. So we just started tailoring workshops to try to help calm some of the paranoia in that regard, using things like videos to kind of explain and show what the virus is composed of. And so as they hear this terminology about the spike protein, you know, we were providing visuals that they could attach to and making sure we communicated it at a level that appreciated their educational background. But the closer we got to the vaccine, we started hearing, you know, there were concerns that as they were hearing messenger RNA, they interpreted that as it's going to damage my DNA, or that this vaccine is going to actually give me COVID. It's also best I just wait it out, let other people get the vaccine. I'll get natural immunity. That'll be better, you know. And people are just tired of wearing masking and having to socially isolate and things of that nature. So just all of that was feeding, I think, some of the frustration with all the quarantining and things of that nature. But there were concerns about infertility. You know, and the Black and Brown communities really felt that this was just a tactic, because particularly as we were spinning off of, you know, some of the social injustice issues, definitely there was a lot of paranoia. People just felt the vaccine came out too quick. How is it that we bypassed all of it? And what did emergency use administration really, really mean? You know, and that this vaccine really was just a way to put a tracking device in us. So right off the bat, we would start off our programs really answering some of those questions and allowing, you know, to, instead of us doing all the talking, allowing them to ask the questions first, and we would just literally build programs around addressing their questions. In some cases, we would farm the questions before the webinar, just to make sure that we had enough time to really address them. So let's move on to the next slide, and I'll talk a little bit more about how we did and who we did what. So as we discovered this paranoia, as we mentioned, we felt we probably need to backtrack and kind of tell a little bit about what's really happening and what really happened with the Tuskegee experiment. Because as we talked to some of our webinar participants, they started sharing that there was this perception that the individuals that participated in the Tuskegee study were actually given syphilis. So right off the bat, we wanted to make sure that we provided facts so they knew that that was not the case. And we were fortunate that one of our national partners had a forum that we were participating in and sharing our story about what we were doing with COVID and what we were continuing to do with cancer care. And we were able to, at that point, interact with a professor from the Bioethics Institute at Tuskegee University. And he agreed to help us pull together a workshop where we actually told or debunked the myths around the Tuskegee experiment, as well as told a little bit more about the Henrietta Lacks story. And most importantly, I think really, which was a home run for us, we were able to pull in individuals on the IRB committee at the university and some of our community members who participated and actually share some of the protections that are in place now for research participation, and also partially because our dean is serving as a co-investigator for one of the investigational vaccines. And so as we're trying to approach recruitment for those kind of studies, we felt it necessary to also disclose and explain a little bit more about why it is that the vaccine is safe, and also what is in place when we talk about research, some of the things that are done to actually protect them. And we really got a phenomenal positive response, you know, from all of that. So these are a few more examples of some of the flyers from some of our workshops. So moving on, you're probably wondering, who are you talking to? Well, as I mentioned, because We Care had started this 10 years or so ago, and we had key people that we had been communicating with in the community, we definitely did justice in making sure we were educating or making the university aware of what was going on, because the university also has launched COVID care initiatives. So we've had nasopharyngeal testing for a while, and we've also had COVID clinics. And the dean and I positioned ourselves on key committees to help with procurement, policy development, as well as policies and procedures for those said clinics. And so in the interim, we've done justice in making sure we've educated faculty, our students, particularly our health students, to make sure that they understood what to expect and some of the ramifications related to storage and preparation of the vaccine, tracking, safety monitoring, and different things of that nature. But we also continue to dig deeper in the community, honing in on our faith-based community, working with groups like athletic coaches, a lot of our private employers. This afternoon, we'll be talking to the Department of Juvenile Justice. I'll be talking with an Arabic refugee group, but we've talked to several groups of the refugee arena, homeless groups, groups that service those kinds of community individuals, and then other associations like our first speaker, where we're making sure that those people who are telling the news also are hearing from reliable sources. And so the list of social and civic organizations that we've interacted with in the last 10 months also has been lengthy, and this is just a cross section. And many of these groups are groups that are embedded in the African American community. However, we have expanded our list of our Hispanic and Latino social groups as well. And we're constantly engaging with them, utilizing, again, their gatekeepers. The pastors have just been phenomenal. They have opened up their churches, to serve and host a lot of the vaccination events. And so we've made sure that we continue to go forward. So next slide, please. And so some of the topics that have come up during our vaccine discussions, because we've just modified the workshops as the pandemic has continued, we made sure to explain how they work so that we can assure people they're not getting COVID. We've talked about the supplies and what that means, because there's been a lot of unrest about, oh, I got my first dose, but I'm hearing there's a shortage. And, what will that mean? What will happen to me if I don't get my second dose, or if I get my second dose too late? What all of that means. Certainly people have freaked out as they've heard about all the variants and the mutations that are going on. People like myself have young children. And so what does it mean in terms of our children going back to school? And unfortunately in Florida, we've not started inoculating our teachers and others. So that there's been a lot of concerns about what's happening at the level of schools. But again, special populations like prisoners, certainly those who are homeless. We've done a lot to explain why the 2 doses are necessary, the side effects, the comparative efficacy, and what does that mean, what's showing up in the literature. And again, as questions arise, we're just trying to make sure we do diligence in answering them honestly and allowing them to see us as a trusted resource. And so we've been able to vaccinate over 2,000 individuals in the last just 3 weeks alone that were having a lot of difficulty just trying to get appointments, and in the meantime, making sure that they've been invited to some of these events as well. Next slide. So some of the challenges, again, that have spurred our persistence with the educational efforts has been because of the registration process. As some of the previous speakers have said, everything has been online, and a lot of our older generation have not had access or just don't have the technology literacy and the healthcare literacy to try to navigate all that's required for that registration process, or they register and don't get calls back, and or we've had a lot of instances, like in the case of my mom, where she was registered registered with the Department of Health. They called back the week she had signed up to go to another vaccination event, and then unfortunately got sick and was hospitalized and missed those events, and we'd had to start all over. So those are some of the kind of things that we've been coming across as challenges in the community, but we're still kind of pushing forward as it relates to vaccine supplies and storage and things of that nature. So we're really excited about having yet a third vaccine become available and have incorporated information about the J&J vaccine into a lot of our workshops as well. Next slide. So what's behind our magic? Well, we think a lot of it is building relationships and maintaining it. So we've included these gatekeepers of sort into our activities. So when we've been fortunate to work with the group to provide a workshop, we asked them if they would be a source of contact, one, for future webinars, and as we've been a part of recruiting events, and that's been magical for us. We've also continued to develop culturally tailored approaches and certainly co-sponsoring events as much as possible. And then using our communication platforms strategically so that we have allowed people to call in so that they can participate. We make recordings available after the case. So if any of you are interested, for example, in the Tuskegee and Henrietta workshop, please feel free to reach out to me. But we do think that meeting with the gatekeepers and having these focus groups, getting feedback from them and keeping a line of communication open with them has really helped. And we've officialized a lot of collaborations, and it's allowed us to continue to broaden our exposure. And I think it's part of the reason why we've been able to participate today. So I'm not sure if time will permit. I'd have to ask the organizers. I know we're kind of way past our time. I did kind of want you all to appreciate a little video that we have of We Care. So I will ask Ms. McGee if that's possible. If not, they can get it in their slides. Yes.
Yeah, so Alana let me know that what we'll do is post the link on the
Okay,
same
great.
place where we're posting the slides so
Awesome.
that folks can access it that way directly from our website.
Great. Well, I think my last slide just had my contact information. And so again, if there's any further questions regarding We Care and or ways that we can continue to work with you all, we would certainly appreciate that. So thanks again to the organizers. This has been a pleasure. I've learned a lot about Ohio in addition, and it's pleasing to know that Florida's not far behind.
Well, thank you so much for sharing information about your program and the approach you've taken. We very much enjoyed learning from you. So thank you and hope you have a great day. Thanks to everyone who has stuck with us to the end. It looks like we a lot of people did, so that's wonderful. We have a poll question for you, and that is overall, how would you rate the quality of this online forum? If you wouldn't mind just responding to that poll here before you leave us today. We'll just hold for a couple seconds while everyone has a chance to do that. Okay, and then I think we'll just go, Alana will just close out then. So we very much, again, appreciate you attending today's webinar. Please take the short survey that will be sent to you via email and share any feedback that you may have about today's event. That you all have a good rest of the day, stay safe, and we'll see you at our next forum in the coming months. Goodbye.